Hi, everybody. You don't know what a joy today is for me. This is a true highlight in to get to talk to Dr. Herbst. A prolific author. I've learned so much about lipedema from Dr. Herbst. Just reading her papers, I've been so lucky to be able to, do research, collaborate on research with her. Just the colleagues, everything good in my professional life, I can trace pretty close to Dr. Herbst, and I am just, what a joy this is to me to get to talk to her, and also about a passion of both of ours. So yeah.
Well, Tom, it obviously, I'm smiling this whole time because I have loved working with you over the years. We have had so much fun. That is the best part of this whole thing, is that it's really been a lot of fun and a lot of aha moments. And I really think that the work we've done has moved the field of lipedema forward and really has made many contributions to it. And I will say that the subject of today, I think, is the pièce de résistance of everything that we have published together so far.
Wow. There is some truth in that, and I'm gonna go into that a little bit, but you're really too kind. You really are. But so I was gonna share just the paper we're talking about here. So this is it. This is the paper that was published just the end of last year. Got in just before.
Yeah, and Tom, you really were the driver behind this. You and your practice collected all of the data that is being reported in this paper. So, big kudos to you, and especially Megan, just because us three worked together so hard on this paper, and just you two were just the driving force, and you really were amazing and in getting all the data together and in finalizing this paper.
It was a labor of love for sure, and Megan did a lot of the number crunching, but we couldn't have done it without you. Without you, how many times did you have to redo the statistics? Oh my God. The going back and forth with the editors, and oh my gosh, it was like I sometimes I was like, are we gonna do, is this ever gonna get done? Is this
Yeah, well, that's the way papers are, isn't it? You think you turn it in, you think you're all done, and you find out that actually really you're just almost beginning.
Oh, I know. Well, but I do think, to a credit to the peer review process, I do think it made it better. There were so many things I wish we could have included in this, and we're going to get to talk about that, because there are so many things that I think are remarkable, and not before noted findings that we weren't able to include in that. But there were, but there was enough to really to make a good paper.
Yeah, absolutely. So we should just dive in, because this paper has, even though we had to leave a bunch of stuff out, it has so much meat to it. And I think people should get it printed out and start writing all over it, because you can get so much information, and there are so many firsts for this paper.
Well, that's that. Well, you know what? That brings me to this slide.
So why don't you review some of these firsts for us, Tom?
Well, this was the first paper in the United States to look at lipedema reduction surgery, also sometimes called lymph-sparing liposuction. It's basically a liposuction derivative. It was the first to document, knee joint range of motion and gait improvement resulting from the surgery. And then it was the first to correlate, patient-reported outcomes you know, using the NIH tools and the SF-36 tools with actual physical measurements. And then
I interrupt you, Tom, just for a second, because I think we should really stress this point. So when patients come in and they report things like pain, difficulty with walking, now you've correlated them with objective physical measurements. So when we go back and we hear these complaints again, we know that they are correlated to physical measurements, and that it's almost objective data when we hear subjective data from patients.
Right. And that's so important because, you know, I mean, so many women with lipedema have their complaints have been dismissed, and it's awful, but you know, this goes a long way to showing that, you know, they're legit, and they should never be dismissed or ignored.
Perfect.
Yeah, and so interestingly, some of the mobility measurements outcome measurements have been shown to correlate with future disability and life expectancy. So I mean, you know, in a way, these correlates, you know, we can point to, like, when payers don't want to pay, how we can say this will affect someone's future life expectancy. Potentially.
Absolutely. And I think that just that in of itself will help continue to ensure that women with lipedema who really need lipedema reduction surgery can get it.
And then, you know, and so, you know, this is sort of my nerd thing. I really was proud that we used the same measurements that they use in the orthopedic literature, in these patient reported outcomes, so that we can say, look, you know, this is total knee replacements. That's like, you know, oh, you need a new knee. Oh, okay, we're going to prove it. Well, we see that in these lipedema reduction surgeries, that they are getting similar improvements in mobility and knee mechanics and quality of life measurements that a total knee replacement is. So yeah, I mean, that's big. I mean, you can't, I mean, it makes any insurer who tries to deny this as necessary, you know, I mean, that's pretty hard to argue with. Not that they still won't try.
Right. And I must say, Tom, you did actually nerd out on this, because I think you wrote a book and we had to actually squish it down to what actually is in the paper.
Oh my God, yes. Oh my God. I had so much I wanted to share about that. And, like, oh my God, God love you, Karen Herbst, because I literally did send you a book, and you got it to, you got it to what at least an editor was willing to read.
So tell us more about knee, you call it knee kinematics and gait, but I guess it's really important to understand that lipedema affects the knee and walking. And go ahead and tell us about the data you got.
Well, so we looked at, you know, these are the two most significant changes we saw with the surgery. And one is the alignment, which is, and I have a slide, I think I have a slide showing it, but basically, you know, are you straight? Is the knee should be a straight hinge? Is it a straight hinge? If it's off, off bent left medially or laterally, valgus or varus, you know, how much is it? And so it, you know, on average, they're about a 6-degree bend before surgery and about a 3-degree bend after surgery. So that's, I mean, that's significant straightening. I actually saw a patient today who had lipedema, very valgus, and she saw an orthopedist who was going to do an osteotomy to straighten it. And I'm like, oh my gosh, no, you do not need to have your bones cut. You need your lipedema treated. Isn't that crazy? But
That's
I mean,
crazy.
I'm so glad I saw her before she did that surgery, because, you know, I mean, oh my gosh. But,
And
you know,
how many women are you unable to see because there's too many? And so this paper, we need to spread it far and wide so other women aren't getting surgery when they really don't need to.
Oh yeah, I mean, but she's like, oh, I'm so knock-kneed and it interferes with my walking, and I'm like, yeah, but you don't need. I mean, that's a pretty. I mean, the osteotomy, that's cutting the bone. No good.
Mm.
Oh, anyway, so all right, sorry, I got a little bit off on a side track there, but I had that patient today, so it was fresh in my mind. And then also, like the knee flexion. So, like again, the hinge, well, the hinge can't close all the way because of the lipedema tissue, the excess subcutaneous fatty tissue. And so they're limited and they just removing the lipedema tissue gets about a 10%, 10-degree improvement in knee function, which is, better than actually a knee replacement will get you. And then, the gait, about 20% before the surgery at a normal gait and about 80% after. So.
Can you say that again about better than the knee replacement will get you?
Well, so if you, oh, you poor, yeah. So average improvement in knee flexion is about 3 degrees from a total knee replacement. So because it's and so this is 10 degrees, so that's 3 times. That's on average. I mean, obviously there's some ranges. There's some in the literature. There's some reports of more and some reports of less, but I'm picking 3 as the average, and so this is quite a bit more than what a total knee improvement in knee flexion. And we're going to go into how I have a couple slides of why that's so important.
Let's move on.
Okay, so yeah, this measuring those knee kinematics, and that's what they call it in the orthopedic literature. It's knee function angles, mechanical angles. That's what they call them. And so this is me measuring that the valgus, and that's like how bent the hinge is, and this is the knee flexion, or how far the hinge can go.
Great.
So this is that little thing. I mean, just basically, so like the difference. This is actually the very conservative estimate, but you need some say 115 degrees of flexion to descend stairs safely. And what you find is a lot of ladies with lipedema, they go downstairs sideways because they can't bend their knee enough, so they trying to prevent falls, and that's a serious problem. I mean, you can hurt yourself with falls. So like, or getting in and out of a car, that's an everyday thing. Well, you need 135 degrees. Well, the average lady with lipedema can't do that effectively or without a great deal of increased stress.
And so if you go back, just in the paper, where did women improve to? Like, what were the average woman in the paper able to do at the end of after the surgery?
So they started at about 115 and they ended at about 125, the average woman. So,
okay.
so now that means I mean, it's all a moving target. Some started at 120 and got to 130 or 135. Some started at 105 or 100 and only got to 115. But yeah.
And this was like, what was the average time after surgery you were looking at, and could they potentially see more improvement, even though it wasn't reported in the paper?
So most of these were like at 6 weeks to 3 months, but some, I was repeating this serially up to, a couple of years, and some got further improvement as they went along. So it's, I mean, we were taking the best. So we took their best, we gave them whatever we could get the best on.
Nice.
And this is that PROMISE thing that this is one of the outcome measures, and this is this NIH toolkit, and it's validated for the US population, which is important as as you know, Dr. Herbst, why? Because, well, I'll just say,
Populations are different in
right.
different parts of the world,
So
and it's important to represent our population.
that's true. Well, but also, I'm sorry, but also because sometimes they'll be like, well, you didn't, this outcome measure you looked at wasn't validated for your disease or patients, but this is for the whole U.S. population, and these were all U.S. citizens, so it's valid. That's what I mean, I wanted to use, I'm really, that's another little nerd point. I don't get to make these with just anybody. Okay. All right. So this is just some of the highlights on the outcomes are
Can we just go back to that promise? I'm sorry, I just a little slow. But I think just I wanted to point out that you can see before the surgery in the orange that pretty much so all the women were below the average value for the US, which is that dotted line. And after the surgery, you could see that more women have crossed that dotted line into the normal range. So more women at the end of the study were normal
yeah.
in their functioning compared to before. And that's huge. And it was highly significant. So.
Yeah, no, I mean that was like that was one of the, I mean, I've been doing research a lot. That's one of the most strongly significant things yeah. So okay, so yeah, so going into some of the individual promise outcomes, we saw 16% in the patient's ability to walk at normal speed. I mean, I mean, that's huge. I mean, you know, so so there was the percentage of people who at the end of the treatment could walk at a normal speed increased by 16%. I mean, I'll take that any day.
Yeah, agreed.
Also, their ability to go up and down stairs, same. So these are, you know, I mean, that's like who doesn't have to walk every day or go up and down stairs every day? And then a 27% increase in the ability for patients to run a short distance. So that's, yeah, I mean, who knows? I mean, you might have to catch a bus or whatever, you know, I don't know. I mean, you don't want to be, I mean, that can really make a difference.
Well, what I hear often is that a lot of women have children and grandchildren that they want to run after. And if they got to run after a kid, well, they can now. So watch out.
Yeah, at least a good percentage of them. And you know, like be able to stand for an hour, that increased significantly. And okay, let's see now. Oh, okay, all right. So this is a nerd alert.
Okay, let me explain. So Tom did a previous study and he looked at conservative measures. And these are the conservative measures, and I'll let you tell him about them. But basically, he was able to show with that previous study that there really was no benefit in knee mechanics compared to this current study. So Tom,
or the mobility. There was no improvement
right.
in the mobility or knee mechanics. Now we did see, so let's talk about this. This is, so, and some of these ladies were in both studies. So now it wasn't randomized for a control. We cannot call this a randomized controlled conservative versus, but we can say that for some of them, they did have the control and didn't see this change. So I'm kind of splitting hairs, but but anyway, so we're talking about medical grade compression, 20 to 30 millimeters of mercury. And then everybody comes through my office, gets instruction on the anti-inflammatory diet, and the vast majority, if they have any signs of significant edema, they get sent for lymphedema therapy, as well as home exercise. We discuss home exercise, and if they are overweight, weight loss kind of strategies. And so that's the core of the conservative. And we did see a decrease in pain and a slight decrease in limb circumference just from these measures. But again, we did not. So only the surgery showed the mobility and the knee mechanics and caused significant changes in quality of life in the SF-36. So yeah, there was with the surgery, we got a 12% decrease in overall body pain.
And that probably was body pain from, everything, but if your mechanics improve, it could be decrease in pain from that. It could be decreased pain from the tissue.
Yeah. It's we can't, but I mean, most women with lipedema, their lipedema pain is what's the, and then, this is just those SF-36s. This is a widely used research thing on all sorts of domains of health. There's 8 domains of health, from physical function to, role limitations, energy, etc., general health. And all of them improved, significantly.
And highly significantly.
Yeah. So, yeah, I mean, that's
quality of life. So whenever we do quality of life questionnaires, this is often the one we use because it's been used so many times. It may not be the absolute best questionnaire ever, but because it's been validated over and over and over, we wanted to use it in this study, and the outcomes were just spectacular.
Yeah, so a 12% overall increase in health, which is, I mean, I'll take that. I don't have too many other treatments that can give 12% overall increase in health.
Yeah, I was going to say, what kind of drug does that?
Yeah. 11% ability to handle daily living activities. So that's pretty good. I'll take it any day and Tuesdays. And 13% ability to complete tasks that were limited by pain, and 10% ability to complete tasks limited by emotional problems. Okay, so here's so a significant percent, probably 80%, had lobules in the thigh prior to surgery, and that decreased to less than 50% after, or right around 50% after. Wait, no, it decreased to almost 0%, right?
Almost zero. So, and this was all in women with stage 3 lipedema, because that's where you see defining lobules. Lobules define stage 3, but yeah, they almost completely disappeared.
Yeah, and then at the knee, almost completely disappeared, and the arm again almost disappeared. So so we're going to talk about that. I think, is that can it be argued that they had a regression in their lipedema stage? I mean, because if they're stage, and this is a question for the expert, if lobules make the difference between stage 2 and 3, and they lose their lobules, do they go from a stage 3 to a stage 2?
I would say yes.
Yeah.
We don't have any other way right now of defining the stages any differently.
So this is just this is an arm lobule before on the bottom, and no arm lobule afterwards. This is what we're talking about. That's bringing that home. This is just a before and after of the lipedema reduction surgery. And then I think I have a knee lobule. Yeah, knee lobule before and no knee lobule after. So
those are nice photos.
Yeah, so here's my point. Yeah.
Yeah. So yes.
Yes. And I'm gonna go with you, Dr. Herbst, because I mean, I don't know anybody who knows more about the diagnosis and staging of lipedema than you, and I don't think there is anybody. So I'm putting my money on you, Dr. Herbst?
Well, I do think stages need to be redefined, but where we are right now, as we mentioned, lobules do define stage 3. And, you know, I've been staging the people in halves because I'm like, well, I can see your lobules forming. You know, that's not good. And so I'm calling them like a stage 2 to 3, which is a 2.5. So, you know, incipient lobules, stage 2.5.
There you go. I love it. I'm going to stop. Is there any slides you want to go back to? Because I'm going to stop the share and we're going to just talk for a little bit.
No, I think I'm good.
All right. Well, but so this is, I mean, is there anything more let's talk more. I mean,
Well, you know, I think one of the things that you did really well was define the population that you were treating. And
oh,
you
that's
look,
right.
yeah, and I think that's really important instead of just saying, yeah, these ladies had lipedema and just running through the paces. You know, you had huge demographic tables outlining their stage, their type, their past medical history, and things that were common. Do you want to, like, hypermobility, migraines? Do you want to
Yeah, yeah.
mention?
So yeah, I know. And they made us put that stuff in the supplement. Oh, thank you so much because I mean, this stuff we did. I mean, we did very, very detailed histories in diagnose in related conditions. And there was a high, so we saw some things that we saw previously, like that you have actually previously reported on increased incidence of EDS hypermobility and you know, obviously increase in
Didn't
lymphedema.
we, wasn't it like 60%?
I think it was 65, and which is
65.
which is I think that's what you've reported. I think that's a pretty close to what you've seen it. We've seen in other studies, both you and I think have other authors besides you reported that.
Mm, not sure. We reported it in our paper that our questionnaire study that we just handed out a questionnaire to women and asked them about their lipedema reduction surgery, and it's about 60% in that. And
Okay.
then yours is around 60%. So I think 60% is a pretty good value. And actually, Steve Dean just asked me, like, you always mention 60%. Why do you do that? And I think it's pretty clear now it is around 60%, but I know it's been reported in Spain to be a little bit higher. I don't know if they published that yet, though.
I'm going to say, I mean, I think it feels about right. Maybe it's a little higher I mean, so as I collect more and more data, I think it was 65 and I think it might be trending a little higher. You know, this is one of those things where if you look for it, you find it much more. And what the problem is a lot of people don't look for this. So, but I think I think as we've talked about before, I think it relates to there's something unique to lipedema tissue, and it is a connective tissue disorder, and I think it affects more than you know. I think this loosening of tissue may have a role in the lymphatics and may have you know, not just around the joints and yeah, we're in vasculature in general, you know, because Shelley Crescenzi showed, excuse me, the network of venous congestion over the knees and stuff. So even in small vessels, not what you see on a general venous ultrasound, they see a congestion over the knees and lipedema ladies where they have a lot of pain. So
Yeah, absolutely.
so you know that's still evolving. We saw you know, a higher prevalence of migraine, and we saw you know, obviously you know, increased incidence of lymphedema. That's, you know, pretty understandable. And we had, you know, we reported on the BMI. So the BMIs, you know, our stage 1, you know, had pretty close to a normal BMI. And then our stage 2 had a, you know, in the low 30s, and then I think our stage 3 was like, in the middle. Are you looking at the exact data? You've got the paper.
No, not yet. No, I did not. I'm
And
just,
so, obviously the BMI went up with stage. I mean, that's not surprising. And, and then we saw, it increase in telangiectasias or spider veins. And we saw, increased in hypothyroidism, but those have been reported before. But anyways, but yeah.
yeah, and I think that, migraines, are thought to be a vascular problem, and that
Right.
goes right along with lipedema. And I'm sure more work in the future will come out, maybe linking those two, and perhaps linking them with hypermobility, because you can't link things together if you're not examining for it. So if you do a study
Yeah.
and you only collect past medical history, but you don't do a physical exam, and then you try to link only past medical history to lipedema, you're not going to find the hypermobility, because a lot of women don't even know they're hypermobile.
Right. Yeah. That's a daily occurrence. And then, we also, and I'm proud of this, we actually, you published, and I think going forward, good lipedema studies should publish the diagnostic criteria used. And that, in our, in all the, methods we, were presented, though sometimes we had to put them in the supplement, unfortunately.
Yeah.
Because
But people can access that, and so I think it's worth it.
well, they publish, the supplements are published. You just have to, I mean, unfortunately, it's all, and I'm really, grateful. It's an open access, so it's freely available. You can download it and read it yourself. And then, but also, the supplements are also available, and you just have to click. They're right next to the paper. You have to download those two separately, though. I wish it was all come down in one, but that's what happens when, that's a decision the journal gets to make, not the authors.
Right. Yeah, true. So how do you think this paper is going to help women with lipedema?
Well, I mean, first of all, I mean, I think it makes very powerful, and highly validated arguments that this will have an overall impact on their health, on their ability to do daily activities, on their walking, on their ability to go up and down stairs, etc. And so these are, I think it's very strong and very tightly validated data to say that. I mean, that should really, insurance companies that don't want to cover this are going to have to really, I mean, they're gonna, I don't know how they can read that and not, but.
Yeah, I agree. They're going to have a hard time saying that lipedema reduction surgery doesn't benefit women with lipedema, but then I think the onus is going to be on women and providers to continue to prove that they have lipedema and not just obesity. So I think we just have to continue to work on figuring out exactly what lipedema is.
Yeah, and then the other, well, but, and also, I mean, let's be honest. I mean, like, I just recently, I read the citations these insurance policies put on as for their justifications when they deny this stuff, and I mean, literally, they are terrible. They literally, they they do not, I mean, they don't represent the consensus medical literature. They find, just the weirdest things to justify their I mean, they basically are finding, they cite things that are, I mean, it's just awful. I mean, they literally are they're basically use find excuses to do what they will do in their best interest of their profits, not the best interests of the patients.
Yeah, I hope that continues to change. Where it's big medicine, it's medicine in the US. We know that we have problems in our medical system. I wouldn't want to be many other places except for here, but I do think that it's incumbent upon us to continue to try and make the medical system better. And I think this paper is one step in that direction.
Yeah, yeah. So, I mean, they just ration it with, with that kind of stuff. So but this will help. This will definitely help. I don't want, I really think
Definitely help.
I really feel like, yeah.
I think it's one of the papers that women with lipedema should include in their packet.
Right. Yeah. You need, if you are submitting, if you have any involvement in your, lipedema coverage, you should cite this. This is as good as a paper as you're going to find to make an argument why they should cover lipedema. And
absolutely.
It's, yeah. So, yeah.
Absolutely. This and the standard of care, hopefully we'll get that revised in the near future.
Yes, but right. So I should include that, should be in there too.
Yeah.
All right. Well, this was so wonderful. What a absolute pleasure to do this and talk with you. Thank you for making the time, and thank you for everything.
Well, thanks for having me, Tom, and thank you for everything as well.
All right, I'm gonna be signing off. Wishing everybody the best of health. Goodbye.